Where's Orlando?
Yeah. All right. Roll call, Shelley.
Right, Alicia Mangrum. Amber Wright. Here. Brian Smith.
On the phone.
Esther T.
On the phone.
Constance Castermarin.
Here.
Garth Gamer.
Here.
Heather Miller.
Here on the phone still.
Jason Payne.
Here.
Jason Johnson.
On the phone.
Josh Gaither.
Here.
Matt Shaw.
Here, go Matt.
Neil Gago.
On the phone.
All right, so we have quorum. We'll start with the chairman's report. Oh, yeah. Could you guys, for those on the phone, please mute your phones. Thank you. Excellent. On the chairman's report, in your paper packet and meeting materials, you'll see the attendance report, attachment 3A. And you can review that at your leisure. Roster vacancy, we have one vacancy, a regional representative, just one vacancy on the PMD committee at this time. And T3G updates, the T3Gs are now posted online after approval by MDC. That resource can be found online now. Fair warning, there's still going to be a process by which we're finding minor clerical errors and things like that that are going to be changed as it is a living document, but otherwise no substantive content changes for now. And finally, there's going to be on the roster for 2020, it's going to be time for the PMD bylaws review sometime in the following year. So that's it for the chairman's report. Mr. Mullins, your report.
I'm actually just going to give the rules update, and I'll turn it over to my co-workers for the remainder. We are in the process of updating several different rules related to ground and air ambulance vehicle license and equipment, and we have just begun work to update the rules for CONs. In addition, I have been notified that we have also got permission to update Article 5, which is our scope of practice and protocol section of the rules. We use the Office of Administrative Counsel to perform this function. It's an iterative process, so each version of the rules that we put on the website, get comments, bring it in for a meeting, have a meeting with stakeholders, it's an iterative process with plenty of opportunity for people to participate. We'll be using the same process for the CON rules as well. On your screen, you'll see a document which just outlines the time frame and scope of the rule changes. The best place to find accurate information is at the Arizona Department of Health Services website. Search out Office of Administrative Counsel, active rulemaking, and it's right there. But if you have trouble locating that, just contact anybody in the Bureau and we'll make certain you have what you need to participate in the rulemaking.
Terry, quick question. It says that Base Hospital is back up for update again. Is that right?
Can you
it shows air, ground, and Base Hospital. I thought we'd already reviewed those earlier.
That's a typo. I failed to get that up there. The Base Hospital one has been completed.
Thank you.
Julia, do you want to talk about EMS for Children?
Sure. So we have our PACES meeting right after this at 1:30. We'll be finalizing, hopefully, the bylaws. We have 3 open roles on that committee as well, which is the EMT, a registered nurse, and then the family representative as well.
And sorry, I missed the motorcycle traffic report. For those of you who have not seen it yet, there was a request from the Trauma Program Managers Group to look a little more closely at our motor vehicle trauma injury information at just motorcycles, and so we produced this report that's available on the website, and then for trauma program managers and agencies, we'll produce a zip code level Excel document that will be placed in the web-based portal where we place reports. Treat and refer, the work group has had 2 meetings now to revise the treat and refer standards manual and application. There was very good participation. The meeting minutes and the recordings from those meetings are available on the ADHS website. With our other committee meetings, there's a column for the special work group meetings.
Clarification, there's no minutes generated yet.
Okay, sorry, no minutes yet. So the recordings are up, right? Okay, so recording. And so we're gonna take the application and revised manual to EMS Council in January for approval. And then for the Cactus report update, we met this morning at TEPI. We, the Bureau, our staff, encountered some interesting technical difficulties while we've been doing this, and kind of gotten some good feedback to make sure that the report is accurate and reflects information that's useful to everyone. And so we have asked for more time to be able to refine that a little bit more so that we honor the process that goes from EMS-RUG to TEPI to EMS Council. And so we will probably complete this in between now and the next EMS Council meeting, but we will give the agencies more time to review their data because we won't present it again until EMS-RUG, TEPI, and then EMS Council, so that we follow the process we've kind of outlined.
Can I make a comment about that?
Yeah.
I've heard Ben give this update 3 times today, and I failed to comment on the first 2. What he's saying is that the staff have who are building this pretty complex program that will run in the background and provide EMS agencies with operational level information on how they can improve their data capture is no small thing, and a level of added service that I don't think. Anyway, thank you and your team for working on that. It's a big deal, big deal.
And just to tack onto that, part of what I was asked to do in coming into this role was to really look at the Cactus data set and working with Ben and Voxel on that. We really want to make sure that as any recommendation that comes from TEPI to EMS Council, there's a lot of discussion at EMS Council about trying to set a standard based on data completeness, but we really didn't feel that the data was ready yet to delineate a standard. And so we're going to kind of go back to EMS Council and say that TEPI has agreed that let's make sure that any data standard put into place is something that's a realistic and good process. So that is where we are at that.
Big deal.
In the future, would that data completeness be part of becoming a premier agency?
Yeah.
Part of the requirements, or?
The goal is, I think the hope was for this go, TEPI would decide what percentage completeness each injury type like stroke, STEMI would need to maintain at or above. We kind of identified some problems. We've had some technical problems. So I think at the next TEPI, we will need to pick that number. And so hopefully that gives agencies enough time to actually look at the report and decide what a reasonable number would be.
But to your point, Matt, because it does tie to premier EMS agency status, if we were to delineate something and we found out a year later that our data wasn't correct, then it definitely would not go over well. So that's why we want to make sure if we set a standard that because of the tie into premier EMS agency, which I didn't clarify, that's a great point. Because of that, we want to make sure that the data is very clean.
All right, anything else from the state?
Nope, that's all I got.
All right, we're going to skip over?
Yes.
All right, so we're going to skip over item 5 and go to item 6. We'll circle back on to discussion and action items. The first item is going to be to discuss, amend, approve the PMD minutes from July 18, 2019, which is attachment 6A. Can I get a motion? Second?
Second.
Jody emailed me the flyers and I put them online. There you go.
Can you please mute your phone? Thank you.
Thank you. All right, any issues with that? All those who approve, say aye. Aye.
Aye.
Okay, all right, the motion carries. Next item B is to discuss, amend, approve the PMD minutes for the special meeting of August 23rd, 2019, which is also in your handouts. Can I get a motion?
So moved.
Second. Okay, thank you.
Because especially in like us, a small department.
All right, any comments? All those who approve, say aye.
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 Just making sure. It just came up on my
Any
calendar.
opposed?
It's weird, man. I'm just making sure. I'll be late.
All
I know
right,
I got
that motion carries, thank you. The next item we will come back to after our presentation, and we'll move on to item D. Discuss, amend, and approve for the format for the drug profiles, which is attachment 6D.
Oh, yeah.
All right, thank you. So this is an example that Allison Welch put together for us, right? Allison?
I think what we needed to do first was show all the other formats, just so if we can do that. If we could please pull up, there should be our current format.
First Arizona format.
Yeah.
All right, so what you're seeing here is going to be basically a prototype or an example of what we currently have on our drug profiles, with the special attention to the appearance of it, the content of it.
My normal route to find them.
Yeah. And so we have a table of contents, and then you'll see basically here's an example of in alphabetical order.
Yeah, we'll do adenosine. So we've kind of got the mock-ups for the same drugs. You can kind of see of adenosine in our current format, a couple other formats, and then a proposed format here.
So you'll see it's got the drug title, a mechanism of action, everything's basically in a bullet format, indications for field use, adverse reactions, and notes on administration. Goes on to a couple pages for this particular example. Adult dosing, pediatric dosing, Arizona drug box minimum supply, and some special notes. And looks like, so in this adenosine example, takes 2.25 pages essentially, in mostly a bulleted format with some subheadings.
I'm going to pull up the NASEMSA one. Thank you.
Now, in the NASEMSA, if you could scroll all the way, it's like 300 some odd pages in. There should be a table of contents just below, and we'll see where it is. There are medications 341. So on the national model guidelines, you'll notice that the medications, if you scroll down to adenosine, so the first thing that's notably missing is they actually don't show dosages. They're showing general information, very, very abbreviated, a mechanism of action, some indications and contraindications, and that's it. So extremely limited, safe to say, not very operationally friendly.
The other, one of the things that I realized looking at these is, if you notice some of the contraindications for adenosine, that conflicts with the current recommendation and training from AHA. So I think these are, when I started going through these, it looks like they have not been updated in several years. And so it's certainly not something that you can kind of copy and paste from. So outside of just not having a lot of information, this part of NISM, so it doesn't look like they've had the time to attend to.
So we have a couple of examples from other states.
Alabama next.
Yep.
Alabama, and if you skip down to page 83 in Alabama.
I'm sorry.
What page was, oh, it's they're labeled 83, so it's probably like 89. So you're doing good.
Looks like we just don't see them. Yeah, so here's adenosine. So this is one of the standouts, right, in terms of formatting. It's got the drug heading, pharmacology and actions, indications, contraindications. It's got some better color coding, some pediatric dosing in a different font, easy to see. And then also, oh, look at that. Is that a visual aid there? A little telephone? How intrepid.
You got your bear. Be happy with your bear.
So the phone logo, as you can imagine, is for online medical direction for that, and the pediatric dosing is very clearly visible. Did you have any other ones, Connecticut?
Yes.
Delaware?
I think one of the things that we kind of talked about is when you look at certain drugs, adenosine is a pretty standard dosing, but other medications, like Versed, your Versed dose for excited delirium versus sedation for an 90-year-old getting paced is a very different dose. And so this can start to get kind of busy. So we had looked at the other state, which this is this one here, I think from Delaware.
Mm-hmm.
And the nice thing about the Delaware one is at the bottom, this instead of giving you a dose on this one, it links you to the protocol containing that. So essentially on the drug profile, you would just link to the specific protocol with it, which then would take you to the appropriate dosing for that drug.
So on this Delaware example, you see all the basic information as you would in any other example, indications, contraindications, warnings, et cetera. But as Dr. Bradley pointed out, rather than listing a bunch of doses altogether, it'll get a hyperlink to the protocols that contain this drug where you can go and get the information that you're looking for.
And we have Connecticut. And then I think it's just the prototype that Allison put together. Oh,
and so this is a profile also using adenosine as an example that Allison Welch put together for us, kind of taking the best of several other examples. There's some color coding here. There's the basic pharmacology and actions, but because of the utility of having the hyperlinks to the protocols that contain this drug, we added that at the bottom there. And this is just illustrated as a potential example for our own future rewrites of the drug profile for your review.
Hi, it's Brian.
Yes, Brian, go ahead.
So the format is fine, but we also have all of those drugs that may go on interfacilities. So those aren't going to link anywhere. Does that matter? Then, but we'd have to have the information in there because we're not leaking to someplace else that may have other pertinent information. So whatever we do, we need to make sure we have the ability to make sure that stuff is getting onto the drug profile also. Because there won't be any protocols for some of those interfacility issues.
So I don't know if you can see the example, Brian, but it's just the last section would essentially be blank. So that the last section is the only hyperlink is the last one where it just says protocols containing that drug.
Yeah, but see there where it says administration, there is no administration. I think the idea here is that you go link to whatever protocol is appropriate and you'll get the administration for that protocol. But there won't be any protocols for the interfacility, so we need just to provide some interfacility dosing like we do now.
Yeah, so you're saying that for interfacility drugs or any other drug that doesn't have a protocol where it's used, we would need to somehow indicate dosing parameters.
Correct.
Yeah, this is Chester. I agree with that. I'm not seeing anything as far as interfacility transfers that would be appropriate to do that.
Mm-hmm.
Or could you make a hyperlink for interfacility transfers and have dosaging put in there?
Well, it seems like at first blush, what you could do is leave that blue box empty and then just add another box underneath that contains dosing parameters so that those folks that are using the in-facility drugs wouldn't need to go searching around multiple pages.
Right.
Right, so have a separate hyperlink for that?
Or just list it in another subheading, but
Sure.
keep it on the same page.
Sure.
Any other comments?
Does it need to have dosing in it? Because they would be working off of their interfacility protocol, which would contain the dosing.
This is at table 5.3.
we have drug profiles for the interfacility drugs currently?
Yes. In the current state drug profile, it's got everything that's been authorized by DHS from the administration to IV infusions. And
some of those, if I recall, are very broad categories. Right, it's not a drug, it is a drug category.
Could you go back to the Arizona one?
And I think the format was something that, I don't think the
first one you
rule
showed us
states
there,
what
there.
needs to be in the
Not
drug
that one.
profile. It's just stating that we need to have a drug profile. So I don't think I can't imagine that rule states we have to delineate dose, route, all of that in a drug profile. So I think I get to Brian's point, yes, we need to make sure that the drug profiles include interfacility drugs, but I don't think there's anywhere that requires us to have that piece of it.
on the interfacility piece, though, one of the things that my organization has found very helpful is that there are dosing ranges in there in terms of titration for certain drugs. And I think that those still probably need to be maintained so our folks have a very defined box into which they need to operate in, and then when they need to contact their base hospital for additional direction.
Yes, I agree. I do see some value. Some of these are going to be impossible, though. Vitamins. Right. How do you give a dose for a vitamin? Plural. Vitamin. So I mean, this allows flexibility, right? You could say for some drugs, put a range in. And as we go through them one at a time, you say select one. And we do primarily those interfacility where you would want, here's the min-max of leaving.
One of the things we recognize in putting together the TTTGs is that we haven't looked at most of the drug profiles in many years. And so as part of that process of updating the drug profiles, do we take the current format and stick with the 2 to 3 to 4 pages per drug, or do we go to something a little bit more streamlined? So we had sent out a request to other, kind of across the country for other formats of the drug profiles just to get some feedback of what's being done. And based on some of them, you can tell some that are kept up to date based on the adenosine contraindications and others that are still back from 10 years ago.
And so, any more comments on what we're showing now?
So kudos to you. I think this looks beautiful. Quite honestly, I like it.
Just Allison.
Thank you, Allison. And
much better.
And so perhaps then as a stated goal, we'll say if there's no objections, we'll adopt this profile as presented with where applicable, we would do hyperlinks at the bottom of the page if it refers to a specific treatment guideline. If it does not, that box will be left blank. Perhaps we can add another color-coded box below with dosing parameters where applicable, and where not, that would also be left blank because there's no mandatory regulatory need to list drug doses for every drug. Is that suitable?
Sounds great. So moved.
Second.
Sounds good.
All right. All those in favor say aye.
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 Any opposed? All right. That motion carries. Thank you. Thanks, Allison, very much as usual. Great work.
Dr. O'Connor is here.
Okay.
Hello. Thank you. Do you have a PowerPoint scheme just to?
I do. Are you here to put on the data stick or plug it in?
What's going to be the easiest way for me to project?
Plug it in.
Sorry? One more for it.
Yeah, do you want to plug it in or do you want to?
While they're getting set up. Dr. O'Connor, who's the Director of Medical Toxicology Fellowship at Banner University Medical Center, Phoenix. At the last PMD meeting, there was a discussion about adding antivenom to the drug box. And so there was quite a bit of discussion back and forth with some recognition that we probably needed to get some input from the experts in the field who manage snake bites and deal with antivenom on a regular basis. We'd asked Dr. O'Connor to come and present and just discuss the different antivenoms. So she is here to do that for us today.
Thank you.
Yeah. Thank you. I know you had a meeting till noon, so thank you for getting here so quickly.
Oh, yeah, no problem. Gorgeous day, right? Typical Phoenix weather. Well, thank you very much. Well, I'll pull up some slides just for fun. I will say some of the slides have pictures of patients, so these are for educational purposes. They do have their faces exposed, so for privacy purposes, it's not, share a lot of this information. Yeah, I'm not seeing it. I'm not. Sorry. Sorry. Okay.
Give me the look and I'll stay.
Oh, okay. You don't have to click it?
Shelley, you want me to go upstairs and get it?
If you want, can I just do it this way? Okay. So just so you guys know a little bit about our group, and why, first of all, no disclosures. I don't have any relationships with any pharmaceutical companies, or I have no financial interest in anything I'm going to talk about today other than the fact that I care for these patients. So we're a group of toxicologists that admit to both Banner University Medical Center and Phoenix Children's Hospital. So we have 24/7 coverage at these two hospitals. We also back up the Poison Center. So one of the things we do through the Poison Center is to try to prevent EMS from being dispatched for inappropriate runs and try to have resource utilization that's appropriate. We also stock lots of rare antidotes, including very expensive antivenoms. And so we're kind of stewards of those medications in these two facilities. And these are my colleagues that some of you may know. Many of them have had relationships in the EMS world or have worked with other agencies with the state. So I'm very fortunate to work with a great group of docs. And then our Poison Center, of course, where we have a direct line to the alarm room. And but what we do as a group is admit 55 to 70 rattlesnake envenomations a year, and that's from kind of all over the state. But folks are flown in, and we stock a ton of antivenom because of those admissions. And, you know, the vast majority of our patients have extremity bites. Occasionally we get more exciting stuff, you know, being kind of a central, you know, tertiary care level 1 tox center, we do get referred, you know, patients. I don't know if any of you have cared for rattlesnake envenomation, but it's really no good when it's on their face. I don't recommend putting a snake in your mouth at any given time. As you can see, that guy's tongue is quite swollen. So we do get more exotic things happening. We definitely have, you know, patients who, this gentleman got envenomated right in the eye, corner of his eye there, and this is his face normally. Like I said, I didn't put black bars just so you can appreciate the degree of damage and swelling that can happen in these patients. This gentleman ended up having anaphylaxis to his rattlesnake envenomation in addition to having a face bite, and he bled into his neck. And this turned out this was his third rattlesnake envenomation, and he had been in the ICU for anaphylaxis due to a rattlesnake bite before. So envenomations can be, you know, quite scary and life-threatening immediately. Most of what we see are a lot of the local tissue effects, so the swelling, the bleeding into the tissues, rapid progression of swelling and pain in the extremities. And then we can see these more exotic systemic effects in which people go down. They have subjective and objective airway edema from the envenomation itself. Occasionally we will get folks who are exsanguinating. They will rapidly develop coagulopathy and they'll start to bleed. They'll lacrimate blood. They'll have bloody diarrhea, kind of more concerning presentations. But probably what most of you are familiar with is the tissue damage that occurs. So they can get blood formations. We end up having to unroof some of these, and they can have tissue necrosis. Rarely we'll lose digits. You know, it takes many days for this to declare itself. But we see tons of just third spacing. People get hypovolemic, hypotensive. We have to give fluids and resuscitate them. And then they just have, you know, they'll even put fluid into their chest wall. So they can be pretty profound. This is just more pictures for fun. But this, you know, we've had patients who have had 2 bites in the same patient, one on the arm, one on the leg. I'll share a case of allergic reaction to antivenom in which the same snake envenomated 2 people simultaneously. So that was a first in 14 years I've been doing this. This is a kiddo who had a compartment syndrome, which we don't often see, but when we do see it, you got to perform fasciotomies, and I think this was transported from down south. The surgeon who was on actually did a self-closing fasciotomy, which I hadn't seen done before, so that's pretty slick. So these are kind of the spectrum of effects we see from the envenomation itself, and sometimes, you know, they can have minimal swelling locally, but yet their tongues will swell, and they will need a rapid airway. So from an EMS provider standpoint, a lot of times it's securing the airway, it's treating shock, it's putting pressors on board if need be, and giving fluids. But the main question comes down to when do they need antivenom, and if they need antivenom, what would you expect the effects of that medication to be? So these are just some pre-hospital management. Obviously, we don't put tourniquets on. There's no compression bandages used in these patients. If a patient does have a tourniquet on, you should take it down in the field. You know, there was with Australian elapids and the neurotoxic snakes, they were worried, you know, they would put compression bandages on, and then there was cases if you take them down, then they'll suddenly get neurotoxic venom effects. With our rattlesnakes, it's all local tissue edema. We don't want to hold the venom into those tissues, you know. So there was some confusion on that, but we do not want compression bandages on these patients, and tourniquets in particular will result in limb ischemia, so take them down as soon as you can. And then you just immobilize, elevate, and transport to healthcare with the intent of getting antivenom on as early as possible. And so we administer antivenom if they have, you know, rapid and progressive pain and swelling, if they have systemic effects, if they have coagulopathy, so if they're bleeding, you know, if they have bleeding abnormalities or low platelets. Back in the day, we used Wyeth's antivenom, which is no longer commercially available, and it was, you know, the main downside of it is it was a whole IgG antivenom, and it would cause a lot of allergic reactions, a lot of serum sickness. It worked great. I mean, you'd give it, and you didn't have to give any more. And then the next on the market was Crofab, and I'll probably I try to avoid trade names, but I feel like it might get confusing in this scenario. Because Crofab is a Fab fragment and Anavip is the Fab2 fragment, and I'll explain a little bit about the difference between those. But Crofab was the only game in town for a lot of years, and just in 2016 we got Anavip approval, though it didn't actually come to market until late 2018. And now in the Valley you're just starting to see it being used more often. Have any of you guys encountered either of the antivenoms? Okay, so which one did you?
Well, traditionally we use Crofab in the ED, but I think I've had one or two where Anavip was given.
Okay, yeah, you're starting to see a lot more mixed. I mean, we're getting kind of that transition period, so some patients are getting both of these antivenoms, but basically it comes down to differences in pharmacokinetics and how these things are made and which species they're immunized against. So with the Crofab, it's 4 North American native species, or species native to the United States, common ones like Western Diamondback, Eastern Diamondback, and so those are actually made in sheep. So they take the venom, they immunize sheep with them, and then they harvest those antibodies from the sheep. They purify them, they cleave it into just the V portion of an antibody, which I'll show you. And this picture says 1,000 words. So just, not that any of you guys love this stuff, but I'm going to be a little bit nerdy here. This is a normal antibody. And if you cleave it here, you would get this Fab2 fragment, which is the Anavip. And then with Crofab, it actually undergoes this papain digestion, and you get both of these small fragments. So the difference between these two antivenoms, one is Crofab is these 2 small Fab fragments, and Anavip is this big V. And the reason that's important is because Anavip stays in the body longer, and so then you don't get delayed coagulopathy or recurrent coagulopathy. These patients end up getting bleeding abnormalities even late, so 7-10 days out. So, and this just kind of shows you what it does. These Fab fragments are administered, they go into the body, they bind up the venom components and take it out of the tissue and prevent it from causing damage. So both antivenoms act to stop progression of swelling. They don't necessarily reverse swelling, and they certainly don't necessarily dictate tissue loss. So when you're envenomated, you know, they say there's some campaigns or ad campaigns that say time is tissue. Time to antivenom will stop the progression of swelling. It doesn't necessarily dictate whether or not that person will go on to have necrosis of the digit or lose the digit. That's often determined at the time of the envenomation and based on what the venom components were. But essentially, the other reason we give this not only is for tissue swelling and edema, but also the bleeding, low platelets, bleeding abnormalities, you give this, it usually reverses it rather quickly. For CroFab, we give 6 vials as an initial loading dose. As Antivip, we give 10 vials. One of the downsides of these antivenoms are that they are very expensive, right? So CroFab, rough numbers, I would say almost $3,000 for CroFab versus $1,100 for Antivip per vial, and we're giving, on average, your loading dose right there is many $1,000s, so this is very expensive. We'd have 6 vials, and I remember being in the ED, and we were trying to reconstitute it, and one fell. We were all putting it in solution, and someone dropped it and hit the floor. So it was like $2,000 drop. So that kind of hurts. So this stuff is very expensive. But from our standpoint, or the standpoint of EMS, the thing you need to know, the main risk of this is allergic reaction, right? Anytime we give a foreign protein to somebody, they can mount an immune response. So hypersensitivity reactions are by far the most concerning issue. If you give this stuff too fast, you can get rate-related anaphylactoid reactions. So patients develop shock. And we never administer this outside of an ICU setting. So I would never give this to a patient on the floor. I put the patient in the ICU, they're on a monitored bed. We administer the foreign protein with cardiac monitoring, continuous pulse ox, and then you give it slowly. So in the beginning, it's a 250 cc bolus that the stuff gets reconstituted in, and you give it like 25 cc's at a time, and then you can kind of gradually double the infusion rate until after you've observed them and made sure they didn't have an allergic reaction. And it usually goes in within an hour. So we can complete the infusion within an hour, but in that first early stages, the healthcare provider needs to know that they're looking for signs of allergic reaction or anaphylaxis. So this was a gentleman who had treated 14 years prior. He made it in the news. And then I treated him again, and he had been given CroFab in an outside hospital, brought to us. We administered the second dose of CroFab, and right in front of me, he developed urticaria, pruritus. He was itching all over. He dropped his blood pressure about 40 millimeters of mercury, so he got hypotensive. So we stopped the infusion quickly. We gave H1 and H2 blockers, and we had epinephrine ready. And after the fluid bolus, his pressure was recovered, and he did okay. But I think that was because I was there at the bedside, and the nurses were there. We were all watching him, and we saw the rash form, and so we stopped it immediately. So that was...
Can I ask a follow-up question there?
Yeah, of course, please.
So once a patient declares in this manner, how does that affect your ongoing management of the reanimation?
Once he has an allergic reaction?
To this degree.
To this degree, yeah. So that's a great question, and there's not a simple answer, right? In the old days, before we had Antivip, the answer would have been we would have based, if he really needed antivenom, how bad his tissue loss was or how bad his bleeding abnormality was. I have had to give patients antivenom that they're allergic to and epinephrine infusions at the same time, which I did not enjoy that experience. And as a clinician, I would prefer not to do that. So that was a gentleman who was a herpetologist who had been bitten several times, but he was having severe symptoms of coagulopathy and thrombocytopenia. So I felt like the risk of him bleeding outweighed the risk of me not being able to treat it as anaphylaxis. So there is an occasion which we would do both. We try then to avoid additional antivenom if we can, but nowadays we have 2 different products, right? So now we have Antivip or CroFab. If you're allergic to one, there should be no cross-reactivity to the other.
Okay.
So I could give you the other one. Okay. So life is much better now that we have 2 products to choose from. So yes, exactly. This gentleman actually ended up getting Antivip. So he was allergic to CroFab, and we were able to secure Antivip and give him Antivip. So that worked out perfect for him. This gentleman, this was the 1 bite, 2 victims version where I couldn't believe it. It's like playing with a snake out in Grand Canyon, and one fang got one guy and the other fang got, they were taking a selfie with the snake, just so you know. Selfies are bad news. He came in and they had neurotoxicity, and they both got treated with CroFab, and this gentleman unfortunately developed pretty severe angioedema, and I couldn't find the picture of his tongue, but his tongue was enormous. Which made us all nervous to the point that we started the epinephrine infusion, we titrated it up. I actually called trauma anesthesia because I didn't like where we were going, and I knew we'd have to do some sort of fiber optic maneuver, possible surgical airway if it got worse. Fortunately, he stabilized, and he did not need an airway. And he came off the epi drip about 8 to 12 hours later. But, yes, question?
When you start the antivenom, what's the time frame that you're worried about for an anaphylactic reaction or anaphylactic reaction?
Yeah,
are you looking
that's
in the
another...
first 10 minutes? Are you looking in the first hour? Are you looking for a delayed?
Outstanding question. all of that. Unfortunately, we start the infusion slowly and we monitor, hoping that we would see a reaction because you would think it would happen pretty quickly. That said, we have done that, haven't seen anything, finished the infusion within that hour, and immediately after finishing the infusion, we've seen it evolve. So it can happen a little bit slower, but, I mean, within the matter of minutes to hours, hour and a half. It usually evolves, but the downside is it could all have already been infused by the time you really start to see it manifest. So that answers the question.
Yeah, and then the other question would be so if you do start epi or if they do start improving, is there any delayed, like we'll see in regular anaphylaxis, sometimes we'll see delayed onset or recurrence?
Yeah, I mean, like other forms of anaphylaxis, you keep them in the ICU, you start steroids, you watch them, you can get them off the epi drip, but then you'll watch for reoccurrence. I can't say that I've seen it that often, or ever. I don't think I've personally seen it. I would have to ask my colleagues. But it's same risk. Anytime you treat with steroids, epi, and you're still going to watch. So that they have to be in the ICU for at least another 24 hours to make sure they're not going to have recrudescence of those symptoms.
Is there any possibility that some of these angioedema reactions in particular could be not histamine pathway, but sort of the alternate bradykinin angioedema pathway that's not amenable to treatment with our commonly used medicines?
Yes, exactly right. So usually with envenomations, you have a high kinin state, or bradykinin breakdown is prohibited. So you actually get your bradykinin levels are so elevated that some of that angioedema is likely mediated by that, or kallikrein.
Yeah.
Honestly, it's more common in ACE inhibitor, patients on ACE inhibitors too, because they already have that. So we've seen 2 of the patients that we've had with angioedema had ACE inhibitors, but when they had an allergic reaction to antivenom, that's how it manifested as angioedema. So it is a bradykinin mediated.
So the reason why I bring that up for those who are pre-hospital is that means that a subset of these allergic reactions are not going to respond to the epi, solumedrol, albuterol, Benadryl pathway. And so you're SOL if you're in a 2-hour transport time or something like that and sitting on this.
This is a 67-year-old gentleman who had invasion to his hand. He had gotten Crofab, but on arrival at BMCP, we only had Anavip, we reserved 20 vials of Crofab, but we were using Anavip predominantly. We gave him Anavip. And this was a prime example where I walked in the room and the ICU nurse had been there, but I don't think she had treated a lot of rattlesnake envenomations. There was a student in there and a resident, none of which had ever treated rattlesnake envenomation patients. And when I walked in, the guy looked like a boiled lobster, and he was tachycardic, and he was breathing like 40 times a minute. And he was complaining of dyspnea, and they said he was getting an albuterol nebulizer because he was a COPD patient, and they thought he was having like a COPD exacerbation. But I walked in, I pulled the covers up, I was like, that's not a COPD exacerbation. So he was, just diffusely erythematous and had urticaria. And so we had to stop the infusion and start epinephrine, and he got everything, H1, H2 blockers, he got steroids. And he did fine, he did okay, but I was a little alarmed that it hadn't been recognized in an early enough state. So from our standpoint, we don't administer antivenom without having ICU level care immediately available. We used to honestly have the epi drips and the steroids and everything at the bedside ready to go. We have been lulled into some complacency because the rate of hypersensitivity reactions are so much lower with these 2 products. And it ranges, you'll see, between 6 and 12%. We know we can get access to these medications pretty quickly. We don't necessarily mix it up and have it at the bedside any longer. But this is still our primary concern with these. And then, with transport, I have had some unfortunate scenarios where antivenom came like on a patient's chest and not infusing, and the patient had like a 4-hour-long transport and didn't get it infused at the outside hospital, and then never got in. And so this poor little kid had this enormous leg because there was a delay in therapy. I've also had nurses take it and throw it in the trash, like mixed up stuff that came with the patient but hadn't been infused in the patient, and $6,000 right in the trash because IV compatibilities or not trusting it was coming from other hospitals, and sometimes that's just protocol, but we don't want to see the stuff get tossed aside. So we've had some challenging cases. But what other questions? Yeah.
So it sounds like obviously your shop is extremely switched on. You're only administering this in an ICU. I think the person who had originally talked about adding CroFab wanted it to be a paramedic because they didn't want to have a nurse. They didn't want to tie up a nurse. I believe that was my understanding. So how many patients are you seeing in tertiary facilities that are getting CroFab that are maybe being brought to, they're probably being brought, because that's why they would be on an ambulance anyway, being brought to one of your two facilities? How long typically from the time are they getting that administration, are they being transferred? And have they had any negative reactions en route? Like, even if it's just anecdotal, I'd just be curious if you know.
I'm not aware of any, because the ones that I know of, like the first gentleman I showed you who had the urticarial rash and the tattoos all over, he actually had a documented drop in blood pressure at the outside hospital. It was given at the outside hospital, and his blood pressure had this big dip. So I don't know if he had some sort of response and it was all around the time that antivenom was given. I don't know if it actually had, I don't know if they were causal or not, because the documentation didn't allow me to confirm the timing. But he may have had some sort of response or adverse event that wasn't detected, but he did okay. And then when he got to me and we gave him more, he clearly declared that he was allergic. As far as, it can be infused within the hour. And then usually by that point or shortly thereafter, you're seeing. So by the time you package somebody up, put them in the back of, one of the ambulances and brought them, you would have probably manifested a drop in blood pressure or something would be going on that you'd be like, oh, wait, this person's had an adverse effect. I hope I answered that question.
So the challenge before us today is basically trying to identify if there's any value to the system, which includes you as a receiving hospital, to have these medications authorized for paramedic level use. The stated benefit is that it would not tie up interfacility cars that are nurse staffed, which are a sort of a prized commodity, and there's fewer of them.
Franco, just to clarify, I think that it's not to tie them up; it's that they're not available at all.
Oh, thank you. Yeah, so it is a precious commodity. There are not many of that resource. And so the benefit would be a faster interfacility transfer if we could use a paramedic level transport. But as the current state is that if we use a paramedic level transport, we can't keep the infusions going. So the question would be, is it the greater safety to have the primary hospital begin the infusion, then stop said infusion to then transport the patient with no infusion running, or do we bring this medication to a paramedic level where perhaps transfers can occur faster with less interruption, but you're now in a sort of an austere environment where some of these patients will have these reactions occur potentially.
Can I just modify that one slide?
Or the other point, sorry, I don't know who I just stepped on. The other point would be that, or would it be better to not start it at all and get rapid transport and start it at the receiving facility?
That's right.
And I think I would offer a third. It's only an hour infusion. Nobody gets a transport within an hour of arrival in the emergency department. So you can finish the infusion and then that's also an option.
So that's what we're sort of hoping to understand. And I'll tell you from the take-home points that I took away are, the allergic reaction is kind of the most front and center. You mentioned that it can happen anywhere between minutes to hours afterwards. The fact that in some places, especially those with the most experience, you are generally infusing these in an ICU setting with cardiac monitoring, et cetera.
Not generally.
Exclusively. And then there's other pragmatic issues, given how expensive it is, and something I just learned now, that it does not seem to predict the degree of tissue loss. Mostly it's the coagulopathy and the progression of extremity swelling and other swelling. And so those are the variables that I'm weighing now in this decision.
Yeah, and Franco, to clarify one other point, too, I think that by the time we get CroFab, to get it mixed and get it hung up, it's completely reasonable to think that a transport, which defined by state less than 30 minutes if it's urgent, would be at bedside around the same time the medication could even be hanging.
I'll tell you from my experience, we brought, so from a very, very austere environment, we took a whole set of initial, enough to treat the first infusion for one victim with an urban search and rescue team that was being deployed in Texas. And within 18 hours, our refrigerator temperature failed. So all of that CroFab was subjected to room temperatures for God knows how long on the first day of our 3-week deployment. So, and we carried around useless CroFab for 3 weeks.
I probably still would have given it if I needed to.
Probably, yeah, absolutely.
Because it's like lyophilized powder and it can be reconstituted.
Yeah.
But yeah. No, I think all I can say from my perspective is that I think it's best served that the patient get the antivenom on board before transport. I would not want to see antivenom not given if we've determined that the patient needs it. I would not, if it could go via transport safely, that would be one thing, but it has to be ICU level care. It has to be somebody who's experienced and can handle either angioedema and or anaphylaxis and allergic reactions. So you'd have to be able to secure an airway safely, and you'd have to be able to start your epidrips and be all over that. But again, I would not sanction anything that wasn't an ICU level monitoring setting. And again, you don't want to have an expensive resource and have it mishandled or disposed of inappropriately. So I think all those things are difficult to deal with, and so the easiest thing is to get it into the patient before they leave the other facility. That's the easiest thing. I will say in the world of Anavit now, the Fab2 fragment, it goes into solution in minutes. So CroFab, the problem was you'd have to sit there and gently agitate it and try to warm it up because you can't shake these things. They're full of protein and they just foam. So you can't get it into solution any faster. But CroFab does take a bit longer to get in solution. Anavit goes into solution immediately. So now you can compound it and get it to the bedside a lot quicker. So as we are transitioning and you're seeing kind of more facilities in the valley using Anavit, I think the time to solution and time to prep and getting it hung is going to be reduced. So if there was ICU level care in the transport, I say by all means, bring the patient with the antivenom running. I would not want to see antivenom stopped for transport. I think that's where I've seen, and sometimes transports are long, right? Sometimes we're coming from rural places by ground, and when that kid showed up and her leg was enormous, I was just sick. I was 4 hours of delay in care. I was just sitting on her chest. It just kind of makes you want to eat.
Yeah.
So you just don't want those scenarios happening.
Any other questions for Dr. O'Connor?
The anaphylaxis is not an immediate onset, or it's similar where you can have it evolve over time. Then the issues in terms of watching the patients, you're still, if you administered it before transport for the sake of having ICU level care there, you're still having risk of anaphylaxis the following hour, 2 hours, 3 hours, 4 hours. So that risk is still there regardless of if you continue the drug administration en route versus stop it and put them in an ambulance 10 minutes later.
I would probably clarify that the risk of anaphylaxis is greatest during that initial exposure. I mean, more commonly, it's going to happen while you're infusing the drug. I was just highlighting that it has happened after the infusion was complete, an hour out. But typically, it's going to evolve shortly thereafter, that hour at the outside. But that's more of the outliers. Commonly, it's going to happen in that time frame. So
just another quick question for style for your toxicology groups. Our Southern Arizona group, when I talked with them about this last week, said that they have really de-emphasized interfacility transport. They're really starting to not recommend that these patients be moved at all because unless there's anaphylaxis, there's not a lot else to do. So at least Dr. Shirazi's advice was when he gets the calls at the poison center, he recommends that they don't be transferred, they just be admitted into the facility.
I will strongly disagree with that statement, and mostly because I've had to follow patients up in clinic who have had bad outcomes, and then on top of it, we care for these patients, and we know because of delayed or recurrent coagulopathy, they need to have labs checked 3 days after antivenom and 5 days after antivenom. So we do that through the poison center or we do that through our clinic. So we're managing these patients. And, a lot of times folks who aren't as, other clinicians, even though you're giving them guidance over the phone and you're trying to help them, if they haven't seen a lot of rattlesnake envenomations, they don't necessarily know how to titrate the antivenom correctly. And so sometimes they get undertreated, sometimes they're overtreated. They also don't always appreciate the compartment pressure issues. It looks like a compartment syndrome, but it's not. So you have to check the compartment pressure. So I think it's best for rattlesnake envenomation patients to be treated in a place that has familiarity with that particular diagnosis. So I do think there's some utility in bringing those patients to a tertiary care referral center that has good follow-up, good monitoring, and has a lot of experience with it. So not to disagree with with Mazda, but
the point is, I think the practice style, just like in emergency medicine, varies, right? So there is some variation. That's it's good to know your practice style.
For Dan on the phone, just so that I understand the context a little bit more, in general, are most interfacility or all interfacility paramedics and interfacility agencies RSI capable?
No, I would say they're not. I would say they're capable of, many of them are medication assisted capable or intubation capable, but I don't know how widespread RSI is across the board. I would say that it's probably not the norm.
I mean, would you feel comfortable for a large interfacility agency the comment was, be able to manage angioedema and anaphylaxis, at an ICU standard of care. I mean, is that what we're talking about?
Yeah, so on my side of things, honestly, if we're talking about managing the airway side of it, and this is not to offend anybody, but the paramedics are far better at managing airways and airway complications than nurses are. It's just not part of their standard training generally. And so I find that we have a lot more difficulty with airway management with our nurses. On the medication administration side, I think the nurses are more competent just because they're used to starting infusions and monitoring infusions, and that's more of their training. So I think you have a plus and a minus on both sides of this. Unfortunately, it all comes down to training.
Either way, is it a lone provider in the back of the ambulance? Because I hear ICU level, and to me that means multiple people providing care. And if that person, has a severe reaction that's not, going to be treatable with, our basic Benadryl and Epi, and you're there by yourself, you potentially are 3 hours or 4 hours in the middle of nowhere, that's a pretty scary place to be.
Yeah, the problem is in a lot of these places there are no resources, right? I mean, there's helicopters throughout the state, but we all know there's plenty of times that they're unable to fly. And honestly, that's where it gets even worse. If they're not used to a medication that now they're having to take on the ground, it becomes even more of a problem.
I guess
but yes, so generally lone provider in the back of the truck, which honestly with requests can be upped. It's much easier to get 2 paramedics in most places than it is to get 1 nurse.
I don't know, from the sound of it, it sounds like your biggest allergic time frame is within the hour of giving it. You give it at the facility you're at. You're going to have somebody transport them regardless. It doesn't seem like there's any benefit after the infusion is given for waiting for a nurse if airway's going to be airway and medic's going to be doing it. So, I mean, I don't know, it would seem like there'd be much more risk giving the infusion on the way.
Just the question is, and to your point, do we add this to the drug profile for interfacility paramedics?
Well, if it's given at the facility, then you wouldn't be giving it intrafacility. So I'd say no, because I'd say have the facility give it where your biggest exposure is, so you don't put the medic at risk as high of a risk for an anaphylactic reaction, where especially if they are not RSI capable, or the problem is the angioedema you're going to get. If you get a true angioedema reaction, it doesn't matter what you do; they need to be intubated, and they're going to still need RSI. So But
But it sounds like it's not uncommon for certain primary facilities to consider such early transport that they haven't even given the first treatment. It sounds like that comes up from time to time, or they'll stop the infusion just to move the patient. Is that a lack of training on the primary
We've had that happen a couple times, and obviously we didn't know that was happening until after it happened, because usually we're being called to the poison center, we're giving the recommendation to give the antivenom, and then we're working on the bed and the transport is occurring. So, now we're a little more diligent in saying, by the way, be sure the, antivenom is infused, before moving that patient out, because you don't want to delay in care.
I mean, if the facility's got, if we're talking about it being given by EMS or being authorized for EMS to give, that means that the facility has it. So it's not a case the facility doesn't have it and we have to transfer. So the facility obviously has the antivenom because they would be transporting it with it. So I'm still thinking if it's an hour infusion, they stay an extra hour in the ER monitored, fully monitored.
Before moving the patient.
With what, I'm sorry?
Before moving the patient.
Before moving the patient while your greatest risk is there.
So if we're talking more rural areas, the sooner we can get that patient out to a definitive care is better. So if I start my infusion and I can continue that infusion right away with a paramedic versus waiting maybe 2 or 3 hours for a nurse car.
If the nurse car isn't going to make a difference, that's not what the issue is. The issue is whether they're going to have an anaphylactic reaction. And that's within the first hour is your greatest ability to have it. And if that's the case, you need an airway. And if you've got a medic that's taking them, even after starting it for 10, 15 minutes, and they crash, and they don't have the ability to RSI or get an airway, it doesn't matter. You're not going to get them anywhere quicker. You're just not going to be able to get an airway, and they're going to.
Yeah, I mean, and with all
Anaphylaxis, what again? Sorry, what was the question?
What was the percent of anaphylaxis?
Hypersensitivity reactions in general are, depending on the study, it's a bit of a range. It's between like 6 and 11 to 12%. So
1 out of 10, basically.
Yeah.
So up to 1.
So, and Tracy, with all due respect, I mean, the concept of sort of the faster you can get them out, the better. I think this is kind of a prime example where that mantra may not be true. There are going to be situations where a treatment modality is started, and you kind of have to say, wait a minute. I mean, cardiac arrest is another example. There are agencies, the high-performing agencies throughout the United States, that will not move the patient until they have not only ROSC, but 6 minutes of ROSC before they go down the road. And so, in Fort Worth, Texas, and then other places, they'll have ambulances pull over to continue CPR before they drive any further down the road. I think this is another example of that, where moving the patient sometimes doesn't always translate into a better outcome. So.
Yeah, I would say with local tissue swelling and edema, typically the most important thing is getting the antivenom on board, and then the transport can come later. It's those rare patients. There are rare patients that are either exsanguinating or in shock from their primary envenomation. Then it's important to get antivenom on board, but then you could also see at a critical access rural facility, you would want to get that patient out of there who's so those are probably, and those are not very common, those patients, but those are going to need to be definitely ICU level equipment. And
sending a lone paramedic to that patient would not be ideal.
Well, no, that's what I'm saying, it wouldn't happen, right?
I was going to say, a lot of those rural places, and I don't know who's in the room, but if there's anybody for a flight there, but I think a lot of those rural places are probably getting flown anyway. Most of them have some sort of an arrangement for flight to get them out quickly, in which case you have a nurse and a paramedic and you wouldn't really have to worry about this.
So let me just pause right now for the sake of time. So can I get a motion to discuss, amend, or approve, so including discussion, adding CroFab and Anafib to Table 3 for eligible agents for
I could make a couple of phone
for interfacility transport?
To amend, or to discuss.
Okay, we have a motion second?
Second.
Okay, all right. Any further questions before we take this to a vote, especially for Dr. O'Connor?
Yes. Can I see the next slide?
No, the very last one. You were left hanging.
Watch where you sit, is that it? Yeah. We've got stories. give me more time. Yeah, no, yeah, so just, look before sitting. Is that what you wanted to say? All right, any other questions for me?
If a lot of these are going to be coming from rural areas, and the infusion piece, is only going to be about an hour. I mean, it's going to take most agencies that do interfacility transports that time to get there anyway. So I mean, I guess, is this a thing, or is this just something that we're talking about? Because it sounds like, in most instances, it's going to just the logistics of getting a unit there, whether it's ground or flight, almost negates whether that drug is going to be done during transport.
But is the option going to be have it there in case it's not finished and you need to get that going?
Dr. Stites, do you want to try to answer that?
I think that the answer was that. Hang on, sorry. Ask the question one more time. Sorry.
So if you want to go ahead.
Adding it to the list in those situations where if flight isn't available or the unit's not available to get there and it's not going to be finished at the hospital, we can get it out faster. Have that in the in there for that purpose.
Yeah, I think I initially approached this kind of with that thought in mind, but if, after listening to the presentation, it sounds like the most reasonable approach is probably just to finish it at the facility and then transport it immediately thereafter. We're never going to carry it in our ambulances. So, that eliminates if they don't have it, we're not going to start it initially by a paramedic. And then if it's already up and running, then the longest you're going to have to wait is an hour. And it sounds like the most reasonable thing to do is to delay the transport that hour before you take them out.
And one thing
I feel like, go ahead.
Yeah, sorry, Dr. Stites, I didn't mean to interrupt.
No
but, as I hear this conversation, I'm putting myself as the provider in a rural environment. The burden, the medical legal burden, falls on the sending physician to arrange transport to the degree of safety that the sending physician feels is appropriate. And so if I'm sitting here with a critically ill patient who's getting Anavib or Crofab, and I'm being told that the only car that can be sent in a timely fashion is a single paramedic vehicle, suddenly I'm now faced with putting my patient at that risk. If the patient has a bad outcome, I eat that. That's my bad outcome, not the Poison Center's bad outcome, not perhaps the transport agency's bad outcome. That's mine. And so I would wonder if I'd even accept that option, or if I would just say I'd rather see the patient succumb here in front of me versus in the back of an ambulance where I have no control while I wait for a nurse car or a helicopter, because at least I can then control that bad outcome myself. And so this seems like a tough situation. Just for the sake of time, though, we should put this to a vote. Dr. Stites, any other comment, or anyone else, any other comments?
No, I've got nothing else.
All right, so we'll close discussion. Can I see anyone who would support the addition of Crotalid antivenom to the list of eligible agents for administration and monitoring during interfacility transport? Say aye. Any opposed? Nay.
Nay.
Okay, the nays have it, and the motion does not carry. Thank you very much, Dr. O'Connor, and that was a productive discussion. I learned quite a few things there as myself as well. Item E, discuss the timetable for continued T3G updates. So we have had, having concluded our T3G update this last time around, I had personally brought up the model of having custodians assigned per topic section, breaking down the T3G workload into anywhere between 8 and 12 or so guidelines per custodian or group of custodians. Obviously we were able to put out a good product, and I'm very proud of the group for the work that they did. but it presented a set of challenges in terms of different custodians who have different work responsibilities and variable times to commit to the project. So an alternate timetable model was brought forward to basically divvy up the T3Gs into perhaps 3 or 4 larger chunks and simply have them as a standing item for 3 out of the 4 PMD meetings per year.
We have 3 PMD meetings a year.
So 3 out of 3. So basically divvying them up into thirds and basically sharing more equitably the responsibility to all the PMD members, whereas the chair would put forth that third of the content to the members in advance of the meeting, perhaps 30 days or so in advance, and then have any comments brought forward as a standing item on the agenda for that section, and then just have that perpetually rotating through the year. The logic being that by the third meeting, all of those amendments and changes would be complete, and the item would be brought forth on an annual basis to MDC for approval. That is the discussion. Any comments, thoughts, feedback?
I don't know if we can do it from a staffing perspective. I mean, if we can, with the other stuff that's on our table, we'd support it, but I have to withhold judgment until I kind of get a feel.
I think the goal is to not have it be as time intensive as it was this time around. So one of the things, a huge thank you for all the work that Franco put into this, and to Shelley and Allison. This really took over their jobs in Franco's free time, getting this done. And so trying to figure out a way, if we have a product like this, that it's kept up on a regular basis. It had been a few years doing this. The hope would be that this is not, that if Franco sends out, here's the 30 to review, you have 2 weeks to send back feedback, and really it would only be content that's actually changed medically. So formatting things like that wouldn't be on the agenda. It would really just be content level changes. So that should be a pretty small, hopefully, workload on a regular basis versus trying to do a big chunk. So I think
not so much and I'm going to push back just because what I don't want to do is I don't want the Bureau to commit to something and then fail. It's actually quite challenging to manage and create the institutional memory of changes in documents over the course of a year. It sounds super easy. It's dramatically difficult given the volume of documentation that goes through the Bureau on a daily basis. So again, I just got to say that we're willing to do our best to make this happen, but I can't at this stage guarantee that we can support it.
So how often are the NSTEMSO guidelines updated?
Approximately once every 2 to 3 years, I think.
2 to 3 years, maybe? So, I mean, because obviously that sort of was the impetus to review these, was the update to the NSTEMSO guidelines. So, I mean, maybe the timeline not being a yearly, but maybe every other year to complete them all and have them done as sort of in line with how often the NSTEMSO guidelines are updated versus trying to get through them all every single year. It's maybe more reasonable.
And NSTEMSO has done, what I noticed is that they had their 2 to 3 year cycle, but then there was like a few intermixed that got changed, and then the whole document got redated at the bottom. So it kind of got updated, and that was what prompted our revision. But then after that date that Franco set out, kind of that version to the whole work group, NSTEMSO put out a new version that there were only a couple things in the new version that had changed. So it was a little subtle that the whole document got redated as January 2019, but I think only 1 or 2 things changed from when it had come out before. And like clearly the drug protocols that are in there have not been updated as part of that project.
Well, I mean, it sounds like, unfortunately, the challenges you brought up, Terry, as far as I like how you put it, the institutional memory and then sort of the iterative changes and tracking all of that is a huge effort. But it seems like whether we schedule it once every other year or we have custodians that do 10 at a time versus the whole group doing 30 at a time, none of that alleviates, unfortunately. You'd have to almost revisit the concept of, is it within the scope of any of these standing committees to do any of these memorialized documents if the task is that problematic, because the document's still going to be there. It's still going to need some tender loving care one way or another, whether one person does it, whether 30 people do it. Those steps will need to still be there. And so I guess the question really then becomes, is there an alternate model for all of this documentation to occur?
Well, is there a compromise available where we do our work and come up with changes, and then the document itself doesn't get changed, but for every year or every other year, we just keep a record of what's changed, and then come with a compilation of all of our changes over the course of 2 years prior, and then we commit to changing the document, say, every 2 years.
I think that's one option, Dr. Kamer. It may be that the Bureau can support the model that you're proposing, Dr. Castro-Marin. I just don't know. And so what I don't want to do is I don't want to, obligate the Bureau to being able to do it when we can't because of our other work requirements as well.
Yeah, that's totally understandable.
Yeah, and what Dr. Bradley said has merit, because you dig into that NSEMSO document, and there were there were guidelines that were updated at various times during the year, and then they stamped the effective date as whatever it was, but there was a whole bunch of changes prior to that. And then another thing that always happens is we sat there and looked at these ad nauseum, and then somebody from the field will come up with something that's an obvious fix for something, and then we're stuck if we can't address it pretty much in real time and then memorialize the change. And then when the document's updated, it's kind of a function of what availabilities you have with the Bureau, but at least we don't miss something that's clinically relevant.
Again, I think that there are ways that we can support it, and we're willing to to work with you on this. Just have to express a little bit of caution.
I think the ultimate goal is to not have a process be the way it was this time, or when Dr. Gross did it, when it was really a massive from the ground up process, because I think that's really what takes so much of the time. I think the hope is that moving forward, as this kind of goes through these processes, since this is our second time doing this, I think a few of us have been involved both times, that both times it took a lot of effort to find a way to make this maybe less time intensive.
And part of the whole effort this time around was to make them more nimble, more easily changed. So maybe it's not as huge an undertaking once we get into this as you might think. So,
and I'll just share one final comment, is that these updates have to take place during open meeting, and we have to follow the publication process and making drafts available, and so so each meeting that we have, even if we do special meetings, they all come with work obligations on the department. But the goal is laudable.
Hi, Brian.
Yeah, go ahead, Brian.
Having been a part of both of those work groups, we made major changes in formatting when the first set of national clinical guidelines came out. We had a very algorithmic, box-oriented system prior to that, and then we ended up putting lots and lots of information into it, which was very time-consuming. We switched that back to a simpler format, and so I think they would be easier. I agree. I think unless we decided to make some big formatting change again, the types of changes that we're going to make to these should be much simpler from here on out.
Based on that, what I would suggest then, this is not a voting item, but what I would suggest is let's see how the next year goes, the next 2 years goes. Perhaps I'll stay on top of the custodians for the time being to at least be the point people to keep their eye on the medical literature and their eye on their assigned guidelines for any critical substantive changes to be brought forth periodically throughout the year. And I can assume that responsibility, just keeping lines of communications open. And let's just see how the year goes. And if it seems like it's very easy and very minimal work, then we can perhaps revisit it in 2020 at some point and see.
Sorry, just real quick, I know we're running late. My one request from a pure operational perspective, having a scheduled review cycle is very helpful for other agencies or medical directors that have to consider these when we make our own protocols. So if you say, hey, we're going to do this every 2 years, it's really helpful if we know that in advance. Super. It is. Okay. Or it's not going to change until 2021. That's also very helpful.
Okay. Any agenda items to be considered for the next meeting? All right, call to the public. Okay, summary of current events, December 3 to 5, Navajo Nation EMS is trauma in the, I thought that said booties, but that says boonies. In the Kayenta EMS Training Center, that's December 3 through 5.
I like that was just a T, not a B, someone goes that.
Yeah, exactly. December 13th through 14th, American Trauma Society's Injury Prevention Coordination Course in Sacramento, California. And March 2 and 3, 2020, NAEMS's 11th Annual Arizona Pediatric Symposium in Flagstaff. I'd also like to remind folks that in January is the National Association of EMS Physicians Scientific Assembly in San Diego, California, if anybody likes San Diego. But that'll also happen, I think, in the second week of January. Next meeting is March 19th, 2020 at noon, right here. Otherwise, with that, we'll go ahead and adjourn. Thank you.
Happy Thanksgiving, everybody.
Thank you.